Hi there, my name is Mark and I'm a trustee of the charity You Can Be a Doctor, and I'm also an anaesthetist working in NHS Fife, and it is my job to give you a little behind the scenes look at what it is like to be an anaesthetist on a night shift. So what does a night shift entail? Well, it is dominated and controlled by these two noisy things. This is my cardiac arrest bleep, or my medical emergency bleep, where if anyone is found to be really sick in the hospital, that they would require anaesthetic support, so that's someone who can manage their airway or help transfer them to critical care. That one goes off, and this one is one of the hospital mobiles, and it basically just means anyone who has a question related to theatre or anaesthetics, they will phone that to run it past me, or to see if they can get my help. So tonight I am covering emergency theatre, something called CPOD. So these are the CPOD mobiles, and later in the week I'll be covering obstetrics, which is all things pregnancy and baby related, and they have their own set of mobile and arrest bleep for things specific to that. Let the fun begin. Although I thought it might be quite interesting just to talk you through what happens at the start of a night shift. You would think your work doesn't actually start until you arrive in the hospital, but actually when you're on a run of 12.5-hour night shifts, particularly during the pandemic, you need to kind of put in your preparation. And for me, that actually starts by making sure that I'm clean shaven, which is one of the requirements to make sure that the proper COVID preventing personal protective masks fit properly and that you get a nice seal. So sadly I'm looking smooth and baby faced, and no stubble or beards are allowed that would impair the connection that the mask has with your face. So actually my preparation for tonight started about an hour before I left the house. You then need to do all the food preparation that you would normally just take for granted on a day shift, being able to run downstairs to the WH Smiths or to the canteen. None of that's available overnight. At best you might have access to a vending machine, but that probably won't get you through 12.5 hours of work. So you then need to do some food prep. Think about bringing something for your lunch and your dinner or your breakfast, depending on how you like to eat. And there's different approaches for each individual person. Some people try not to eat overnight. Some people just treat it as if their body clock's flipped and they have breakfast, lunch and dinner, but at ridiculous times of the night. Then arrive, I immediately go to the changing rooms and put on a fresh pair of clean scrubs and my fancy theatre shoes. This is so that I'm not bringing any bugs or dirt from outside into the kind of clean operating environment, and also has the added benefit that if I get blood or some other stain on the clothes, I'm not taking it home with me in the opposite direction. And unlike our medical colleagues who have to wear shirts and sometimes ties and chinos, it's really comfy, and I basically get to work in my pyjamas all night, which is quite nice. I then go and find my day shift colleague who I am taking over from, because we provide a 24-hour service, so there should always be an anaesthetist on call and available. And I am the resident anaesthetist on call, which means I am present in the hospital and the kind of first to respond to any emergencies or calls. And I will be supported by a senior consultant anaesthetist who will be available within 30 minutes. So for most people that means living quite close to the hospital, but for some of our colleagues who live further away, they'll find a bed somewhere in the hospital grounds so that they can respond a bit quicker. I then get what we call handover. That's where the day shift tell me everything they think is important for me to know going into my night. So whether that's about patients they're hoping to operate on overnight, or patients who've been sick during the day that they'd like me to review, that's where we hand over all that information. And then I inherit the dreaded bleeps. This is the way in which the hospital keeps in touch with me and makes sure I'm busy. So you have the mobile, which is where people phone to give me verbal referrals, and then if something's a bit more urgent, you have the emergency bleep, and that typically goes off if someone is in imminent danger, and or if their heart has stopped beating, something we call cardiac arrest, and they require me to respond straight away. So for many doctors, these noisy things are the bane of their life, and you'll find after your first few years as a junior doctor where you are harassed by these pieces of equipment, you'll find yourself waking up at home thinking that you've heard a bleep go off with some form of post-traumatic stress. So that's that. Tonight I'm covering the emergency theatre. We provide resident anaesthetists to cover emergency theatre and obstetric theatre because both are typically busy overnight. So I do have a colleague floating around in the hospital somewhere, which is always nice to know. And we essentially work as a team, and that's one of the big positives of working for the NHS, working in the hospital and being an anaesthetist. You are part of a bigger machine. You are an integral cog in the wheel, and you all work together between the other doctors, nurses and support staff. So it's a real privilege. And I'm feeling pretty fresh so far. The coffee's obviously still working, so we'll see what I'm like in, what is it? See what I'm like in 9 hours time, shall we, when I'm trying to drive home. So we have just been called down to A&E. There's been a road traffic accident, and one of the patients requires anaesthetic support. So this is the joys of the job. You never know what you're going to get. Let's go and see what's waiting on us. Hi, it is future Mark here, as you can probably guess by the fact I've now managed to grow out a patchy beard. I just thought I'd quickly fill in the gaps about that last patient that I went down to A&E to see after the road traffic accident. I went down there assuming they would need airway support. As an anaesthetist, that's often what my job revolves around. But actually it was a patient who in the crash had quite badly dislocated their shoulder and was quite agitated and distressed, and the A&E docs were really struggling to relax him enough to try and pop the shoulder back in. So they just needed me to kind of go and lend a hand. We can administer either gases to help people relax, like Entonox or laughing gas as it's more commonly known, or put in a drip and give people some medicines just to take the edge off and help them relax a bit. And with that, and through cooperation with the A&E team, the shoulder is back where it belongs. Now back to night shift, Mark. The fun continues. We have been called down to A&E this time for a patient with something called a quinsy, which is where you have an abscess or a big boil inside your mouth around about your tonsils, and that can make it really difficult for you to open your mouth or swallow. And so anaesthetically, if I'm trying to secure someone's airway, that can be quite challenging. But the worry is that the abscess gets too big and it obstructs their airway. So the ENT surgeons like to drain them, but it can be a challenge to manage their airway. So they're often best dealt with sooner rather than later. So I'm going to go and say hello to them, see how bad it is, and see how quickly they want to go to theatre. Oh, hi there. Future Mark again, enjoying the post-night shift stubble. the Quincy patient that we went down to A&E to see was actually really, really interesting. So a Quincy is a peritonsillar abscess, so an abscess at the back of your kind of oropharynx, which makes it really, really difficult for you to open your mouth. And so surgically it has to be drained, but obviously if you're struggling to open your mouth, it's very difficult for the surgeons to get in, but also becomes very difficult for the anaesthetist to secure the airway and make sure that when you're asleep, you're still taking the appropriate breaths and oxygenating and ventilating. So the patient's mouth, you could literally only open it about 1 centimetre, kind of like that, if you can't imagine what 1 centimetre is, which is not enough room for us to do laryngoscopy and put a tube down as we normally would. So instead, I had to call in the boss, my consultant, and we did an awake fibre optic, which is literally where we use a tiny, almost like a straw, fibre optic cable that can go either down the nose or in the mouth, with a little camera on the end, and we pass that down into the airway with the patient awake, using lots of topical local anaesthetics so that they're totally numb, and tolerate it as best as possible, and then slide the endotracheal tube over the little thin camera, and then once that's in place, we then pop the patient off to sleep. So it is a tricky skill, and one which requires a lot of patience and a lot of communication with the patient, because it can obviously be quite distressing for them. But luckily, the patient was a superstar. It all went really well. His Quincy is drained, and he is going to make a straightforward recovery. This is just coming up for 6:15 in the morning. It's been the end of a very busy night shift. Seems to have been dominated by emergency theatre due to patients bleeding from their digestive tract, requiring surgical intervention. So it's been a bit relentless. A lot of what the hospital calls major hemorrhages, where they trigger a pathway that sets in motion a sequence of events to optimise the care a patient receives, make sure they get blood as quickly as possible, and that the appropriate doctors and nurses are made aware as quickly as possible. So the anaesthetist is a key part of that pathway, and so we've been heavily involved. Luckily I've been on with a great team, so we have managed it together on the most part. So hopefully in the next hour and a bit there isn't too much else going on and we can pause and have a cup of tea. I thought it might be quite interesting to have a quick look at an arrest trolley. So as I've mentioned already, being the anaesthetist on call for the hospital means that you respond to medical emergencies around the hospital, and that includes cardiac arrest. That is probably the image you think of when you think of like a hospital resuscitation, where it's all quite dramatic and they're putting on paddles and electrocuting the patient and giving them adrenaline and all this sort of thing. In reality, because we're drilled in these things, they tend not to be quite as dramatic, albeit they can be quite stressful. But to try and minimise the stress of the situation, we have a universally designed and organised trolley situated on every ward and every area of the hospital, so that in theory, if you get called to an emergency, regardless of where it is, you should be able to find the drugs, the kit that you need. And it's designed in such a way as to try to be as foolproof as possible. So on top you have the defibrillator. That is the device that will shock the patient to try and kickstart their heart. We have some oxygen on the side. There is what's called an ambu bag. That's a self-inflating bag that we can use with a tight-fitting mask on the patient's mouth to help support their breathing. At the side here we have a portable suction device That's so that if we are trying to clear out their airway and there's lots of blood or sputum or sick, we can clear that, and that gets sucked up through there and into this canister here. And then we have the drawers designed in such a way, you might, if you have a first aid certificate or if you've done any first aid or basic life support, you hear about the ABC of patient management, and that's where you focus on airway, breathing, circulation. And the drawers are generally organised in that order because that is the order of priority. You first of all want to secure a patient's airway, you want to support the breathing, and then you want to support their circulation. And in reality, if the resuscitation team is working well together, all those things are happening at the same time. But we can have a little look. So in A for airway, you have what's called oropharyngeal devices, which are basically little plastic tubes that just sit in someone's mouth and kind of opens up their airway to make it easier for the air to pass in and out. We have these fancy bits of kit called iGel. No, it's nothing to do with the Apple craze that is taking over the world, but instead they are rubber airway devices that sit in the back of the throat, and you can ventilate someone through that, although it's not a completely secure airway because they could still vomit and that go down the wrong hole. And then you have these things called nasopharyngeal airways. So whilst the oropharyngeal, oral, mouth, sits in the mouth, the nasopharyngeal, yep, you guessed it, it sits in the nose. Imagine having that down your nose. So you can imagine how unwell these patients are that they're tolerating us shoving something that's bigger than a biro pen down the back of their nose to try and open up their airways. Need to make sure I put everything back the way I find it, otherwise it becomes an issue for when the next person comes across it. The next drawer down is for much more serious airway intervention. This is where the anaesthetist comes in, and that's if the patient needs what's called intubated. And as the name maybe suggests, intubate, we put a tube in to their trachea, their windpipe, and that is a secure and safe airway. And these tracheal tubes look a little something like that. So if you imagine that's going all the way down and sits somewhere around about here on the patient. It's a flexible, semi-rigid tube, and we inflate the cuff at the bottom there, and that holds it in place. We then tie it around the neck or tape it to stop it going anywhere, and we insert that with the use of a laryngoscope, which is a metal blade on the end of a torch handle, which has a light in it that helps us lift up the patient's mouth so that we can see all the way down to their vocal cords, so we can see the tunnel that we want to travel through in order to get into their windpipe. We also have additional things in here, so we have filters which are good for humidifying the air that we're giving to patients, and also acts to filter and clean it. We have McGill's forceps, which are basically for, they're like long pincers that we use for grabbing bits of debris and things. If a patient's been sick and there's a big lump of potato sat on top of their vocal cords, we don't want that going through the hole, so we use them to grab the foreign object. And that can be anything from food to a tooth to a toy or anything. There's also a stethoscope, probably something that you are most familiar with. This is the tubes that we put in our ears so as to listen to a patient's chest, their lungs and their heart, and that would help us confirm that the tube is in the right place. And then we come down to the next drawer, which is C for circulation. So this is everything related to the heart and blood. So in here, I'll flip my camera around so you can see it a bit better. We've got tubes for taking blood. We have what's called butterfly needles for getting into the vein, blood gas syringes, cotton buds for once you're done, very important, otherwise you make a mess and the nurses get you into trouble. various syringes, and then cannulas. These are the little plastic tubes that sit in patients' veins. You've maybe seen them on the back of people's hands or on their arms, and it's through them that we're able to give medicines, infusions, fluids. And then in the bottom drawer, you can call it, if we're saying A, B, C, then we would call this one D, and in there is a drug box that has our emergency drugs in it that you're most likely to need, so that they're to hand, and various other bits of kit. Essentially this is a bit of a miscellaneous drawer. And that is that. We try to keep it as simple as possible to try and minimise the chances of mistake or error, and there will be a nurse or a member of staff whose job it is every day to do an inventory of that trolley, wherever it is in the hospital, to make sure it's fully kitted and ready to go. So hopefully that gives you some insight into what we do when we're called to those arrests. So this is my second attempt at leaving the hospital on my penultimate night shift. I got all the way to the staff car park and realised I'd left the car keys in my locker back up on the first floor. So that's we'll put that one down to night shift brain. I'm being a bit tired. So home to bed for the last time, and then one more shift. Woo! Hello. So the clips you've just seen are from a combination of my night shifts to give you a flavour of, excuse you, how varied a night shift can be in the hospital, particularly when by the nature of night shift there's a lot less staff around, and at times there's only me and one other anaesthetist to take care of whatever the hospital throws at us. The clips coming up are from my following nights where I was covering the obstetric unit, so that's pregnant women and all things related to labour, and it will also include a very exciting tour of an anaesthetic room and what an operating theatre actually looks like, if you haven't seen that before. So I hope you enjoy. Arrived at work. This is night shift 3. You find as your night shifts go on, you get into a bit more of a routine, a bit more of a rhythm as your body clock starts to switch. So managed to get a good kind of 6.5 hours sleep today, fairly uninterrupted, despite a few Amazon delivery men doing their best to wake me up. But had my car coffee, listened to a podcast, and feeling raring to go. So let's go and make some magic happen. So it dawned on me that a lot of people who may be watching this video have never actually been in an operating theatre or an anaesthetic room. So I thought I'd very quickly just give you a quick tour so that you see what my work environment is like. Tonight I'm on for obstetric anaesthesia, which means I'm providing anaesthetic to pregnant women. So that can be in the form of doing an epidural to provide pain relief by giving anaesthetic and painkillers into their back, which numbs up the area where they are having cramps and pain. Or it can be caesarean sections, which can either be done regionally with a spinal anaesthetic to make them numb up to their chest, so that the procedure can be done with them awake, so that when the baby comes out, both them and their partner are present and able to share that experience. Or if for various maternal or medical reasons the patient needs to be completely put off to sleep, we can provide a general anaesthetic. And often when these decisions are made out of hours, things need to happen very quickly. So again, it comes down to being extremely prepared for all possibilities, and that's how my shift in obstetrics will always begin, with me coming into the anaesthetic room and making sure it's set up exactly how I want, and that the drugs I am most likely to use overnight are pre-prepared and labelled, and I can just grab and go. So I'll flip the around the guys have been in doing a bit of cleaning, so it doesn't look exactly how it normally would. These boxes and suitcase would normally be in the corners of the room. But we have 2 fridges, each containing particular anaesthetic drugs that we may require. In this one, I keep all the immediate drugs I'm likely to need. So these are my emergency drugs to help boost blood pressure and heart rate if that were to change. This drug helps the uterus tighten up after the baby's been delivered, and that helps to minimise blood loss. And there's various other things. We have a cannula ready if I need to pop an extra drip in a lady. More medicines if I need to top up your epidural, and a tray of anti-sickness and antibiotics, which we normally give when people come to theatre. We'll then go into the theatre room, where you can see our operating table, and at the head end is my anaesthetic machine. That's what I use to anaesthetic gases, or to check the patient's observations, heart rate, blood pressure, oxygen levels. We have various infusions and drip stands. These pumps here slowly inject medicines that I set up. Elsewhere I have a cot, so the midwife normally stands here, and when the baby comes out they get planted there, dried off, and provided all is well, they get handed off to mum. If there is an issue with the little one, they get taken through these doors where we have resuscitation facilities for babies. So that's called a resuscitator, and there's a couple of them just in case there's multiple pregnancies. And this room's always kept quite nice, warm and toasty, because newborn fresh babies like to be kept warm and get cold very quickly. Elsewhere again, as we're talking about being prepared for all eventualities, the theatre staff have got the surgical equipment out and ready. It just needs to be opened up, and we can pretty much move from the ward to theatre in a matter of minutes, and the baby will be out not much longer after that, which is pretty cool. But it can be quite fast-paced when those situations arise. On our ongoing tour of the theatre area, welcome to paediatric recovery. So this is where we bring the children after they've had an operation, and by child I mean anyone under the age of 16. But if you have a look around, it's just a little bit more colourful, with some nice pictures on the wall for them to look at. There's a few kind of books and toys and things that they can play with. In reality, they're all kicking off and just want their parents or their guardian, but we try our best to make it a bit more friendly. Well, we made it. It's the end of night 4. Just need to survive the drive home. Wish me luck! A truly super busy couple of shifts, but we have made it to the last one. We finally got our takeaway. So you know, there's lots of downsides to doing nights, but there's plenty of advantages as well. You know, I've been on with the same team the whole time. We're like our own little anaesthetic family, looking after each other. You get to order in some takeaway, you get to eat some junk food, you can sleep during the day. It's quite nice. So yeah, and like on your nights when the workload settles, there's an opportunity to kind of catch up on admin. You can even just chill out, read a book, watch something on your iPad, and actually there's a lot of evidence to support having small kind of micro naps and rests on your shift when clinical priority allows. So yeah, we just have another 6 hours or so to go. 3:30 in the morning, and we have just finished one of our emergency procedures. I'm covering obstetrics this evening, which is pregnant women, and I was called to a major obstetric hemorrhage where a lady, after delivering a baby, they weren't able to get all of the placenta out, and so that causes a lot of bleeding, and the only way they can fix it is to go to theatre and have a proper look and stitch things that need to be stitched and remove anything that shouldn't be there. So it's all pretty fast moving and requires lots of coordination, communication and leadership amongst the team, but everyone worked fantastically, and this is us just tidying up and making sure we're ready for when the next emergency goes off, because so much of our jobs as doctors and nurses and support staff are to be ready for the emergencies when they come, and sometimes they don't come, and that's great, but when they do, we need to be able to do things in a very time efficient manner. And so it's my job now to kind of restock the drugs that I've used, because we could just as easily be about to go again in 5 minutes. So I'm also going to use this opportunity to have a drink and go to the toilet. So it is just gone 4 o'clock in the morning. We've been called to do our third emergency section. Luckily I've just brewed some fresh coffee. I'm going round to see the lady just now and then get theatre ready and probably have a baby delivered within about 30 minutes, so wish me luck. So that is now just gone 5:30 and we have just finished our third emergency section of the night. Another happy healthy baby, which is good, but no rest for the wicked, so I just came back to the anaesthetic room to get my drugs ready just in case they want to do it all again. So we will see. It's, as we've said, it's all about being prepared. Something's making a noise which is annoying me. Let me go and fix that. So yeah, we'll see if we need to come back. We had to take another emergency caesarean section to theatre for a lady that we think had an infection. Baby was also breech and getting a bit distressed, so it ended up being a general anaesthetic rather than doing the spinal in the back. So I'm just catching up on some paperwork now, documenting what I did, hence I'm getting away a bit late, but it went well. We have a happy healthy mum and a happy healthy baby, so what a privilege to be a part of that part of someone's life. So that is the end of night shift 5. Not had many updates from me last night, just because we were extremely busy, and none of us really got a proper break until we were just about to finish. So a bit relentless. We ordered in a wee takeaway, and my Chinese just got cold. Sometimes happens with the job when you're on call. You can't really predict when it's going to be busy or quiet, so you're always encouraged to take your breaks when you can, and there was never a point that it was safe for the patients for us to, or for me to pause. So but it's fine. It was actually made for an excellent shift. We did 3 epidurals and 3 caesarean sections, so that's pretty good going, I think, for a night shift. Definitely earned my bed.